This is just a short talk on the management of the neonate with, I realise I've got a typo, I'm sorry about that, but congenital heart disease in the first hour after birth. So some considerations. So as we've already heard, this is quite a heterogeneous group. There'll be some babies who we need to do nothing additional to what we would do for any other baby, and some babies who will have an awful lot of things happen to them in that first hour of life. So without going into every single condition, this is just more of a generalized look at how we manage these babies. Some aspects of the care are the same as babies without congenital heart disease, but there are some additional factors that we need to consider, and we've already looked at the place of birth. So when we have our daily huddle, we hear about all of the babies that are due that day, be they planned deliveries or ladies that have recently presented, and that'll include hearing about babies with congenital heart disease. So in preparation for these babies to be born, it's really important that we have a look at the notes. The information we receive from delivery suite may not be entirely correct, especially for the more complex diagnoses, and look particularly for letters from fetal cardiology that delineate the plan for these babies, whether it's that we're going down the palliative route, whether or not these babies need early assessment, whether or not we're starting dinoprostone for these babies. So it's really important that we know and are prepared before the babies are born what pathway we're going down. If there's new concerns, particularly if, for example, the baby's being born prematurely, we'll try and speak to the family antenatally, but hopefully most of these families will be very well counselled about what to expect. And any preparation that we need to do we need to pull up any particular guidelines, for example, for the hypoplastic left heart babies? Do we need to make sure we've got the medication prepared? And do we need to alert cardiology in advance if we're expecting a baby that's going to be unwell? So now our management in the delivery room. So the first thing we need to consider is deferred cord clamping. So deferred cord clamping is something that some of you may be aware of, some of you might not be. And that's something that's been much more prevalent in recent years. And that's a change from when the cord used to be clamped immediately to leaving at least 60 seconds, if not longer. And we know that for babies without congenital heart disease, there are loads of benefits. So for term babies, that increases their iron stores and their HB levels, and there is a correlation with some improved fine motor and social development later on, possibly as a result of less early anemia. And in preterms, there's a whole world of benefits: less hypotension, less IVHs, less anemia, decreased mortality. And we only not do it if there's a need for urgent resuscitation or a condition needing immediate management, such as a diaphragmatic hernia. For babies with congenital heart disease, the evidence for deferred cord clamping is much more limited because these babies are often excluded from big trials. It's assumed that it would be advantageous, but it is quite, as I said, quite a heterogeneous group. There's been some studies, a pilot study, which has shown that it is safe and feasible to do deferred cord clamping in congenital heart disease, and the main difference that we see is that there's fewer blood transfusions needed in the early treatment pathway for babies that had deferred cord clamping. So deferred cord clamping is part of our standard treatment at the time being, unless, as I said, it's an unwell baby or we need urgent management for some other reason. Consider skin to skin. So if it's a baby that we do not need to urgently assess, then like any other baby, that baby could go straight to skin to skin. So, for example, VSDs or AVSDs, potentially babies that there's a small risk of a coarct and we're not quite sure. Otherwise, if the baby is thought to be high risk and comes straight to us on the resuscitator, we'd attach a SATS probe to the right hand, which is in the vast majority of cases. Obviously, we're talking about complex cardiac, but the vast majority that will be preductal. If the baby is born in poor condition, because as we know, these babies can also have all of the other problems that we see with any other baby. So if the baby's born in poor condition for other reasons, we do NLS as required, except for in the cases of a pre-planned palliative care, and we'd aim for delivery room cuddles before we bring the baby across, if hasn't already happened. And delivery room cuddles are again something that in the last few years we've really tried to promote, and that is cuddles or skin to skin before bringing the baby to the unit, for as many babies as we possibly can, and that's across all gestations, even our very premature babies, unless the baby is too unstable to do this. This is because it facilitates early bonding. It helps with expressing, which is really important, particularly for cardiac babies who may only be limited to having breast milk. And there are some babies that are too unwell for cuddles once they come to the unit. So if they end up having very early surgery, or attached to lots and lots of monitors, parents may not be able to cuddle them because the baby's too unstable, or the parents may be too nervous or frightened to have that first cuddle. And this is something that's been really well received by both the families and the staff. So bringing the baby to our unit, we practice what we call the golden hour. So that is trying to get everything that needs to be done for that baby done within the first hour. And then we can leave that baby well alone, apart from obviously cuddles and all of the nice stuff rather than all the horrible medical stuff. So we attach all the monitoring, and that usually includes pre and post ductal saturations, so right hand and one of the feet, ECG leads. We usually obtain, if the baby needs to come to the unit, we are at the point where we usually need to obtain IV access. If we're thinking of starting prostaglandin, which is dinoprostone now in Yorkshire, we want to establish reliable access, and that's usually central access. So traditionally that would involve putting in a UVC, because that's the quickest and most reliable way to get reliable central access for our babies, particularly our smaller and more preterm babies. There are some babies that we expect will come to us only very briefly and be assessed before they're moved toward 51. And in some of those babies, a long line may be preferable, because UVCs are less favoured in the cardiac ward. So that's a case by case, but we should be looking at some more definitive IV access. Any bloods that need to be sent, so usually as a baseline we'd send a group and save in preparation of any procedures, full blood count and a blood gas to look at the lactate. Any other considerations, so as I said, all of the normal baby things happen, so there could be concerns about sepsis, we may need to start antibiotics, and that would be the same whether or not there was any congenital heart disease, and the commencement of any other medications as per the antenatal plan and assessment of the baby. We would obviously alert the cardiology team, but depending on the urgency of the case, the timing may vary. So for example, if it was an overnight delivery of a baby expected to be very stable, we may not bother the cardiology veg overnight, but usually we would stabilise the baby and then call them to update them with the baby's condition, any gases, blood pressure, etc. And occasionally, if there's any urgent treatment anticipated, such as a TGA with poor mixing, TAPVD or anything like that, occasionally we may alert them in advance so that they can be ready to be present for the baby and any procedures that they may need. Other considerations for these babies, so if we were expecting any procedures, for example, as I said, a TGA with inadequate mixing, we were expecting a septostomy, we may be prepared to intubate that baby, and sometimes we even intubate the baby there in delivery suite if the baby's saturations are incredibly low, just because we can get it done more quickly, get the baby across and crack on with things really quickly. Consider whether we need to send any genetics. So if the baby has any very obvious dysmorphic features and we're worried about syndromes, that may affect the treatment going forward for that baby. So for example, if it turns out that baby had Edwards, it may not be then appropriate to, it wouldn't be usually appropriate to offer any surgical input. So if we think there is an underlying syndromic condition, then we would want to send that genetics off as soon as possible so that then we can speed up making plans for the baby. And we need to consider feeding. So recently, in the last year or so, we've been lucky enough to have a a joint cardiology feeding guideline, which is really helpful in stratifying the risks to these babies, and whether or not we can move forward with feeding immediately, or whether we start the feeding much more gradually or hold off feeding for the high risk babies. Usually breast milk is the preferred milk, or the only milk that babies can have due to the association of NEC, necrotizing enterocolitis, with particularly the left-sided cardiac lesions. So we encourage mum to express really early so that milk can, so you can start helping with the milk to feed the baby, and considering whether we need any PN if this is a baby we're not going to feed for a while. And it's also really important to update parents, because they'll usually be, there's always a lot of fear when we admit a baby to the neonatal unit, but particularly with babies with heart conditions, the parents can be understandably incredibly anxious. And also what we see postnatally sometimes doesn't correlate with what was expected antenatally. So it's really important we keep the parents up to date as possible and try and have them there on the unit with us as much as possible. And then it's important for us to know the ongoing plans for that baby, so that we're not bothering the cardiology team all night with worries about SATs and questions. So things that we'd like to know for this baby is what's the target oxygen saturation and what are the expectations. So for example, for some babies who are, say, a duct dependent, for the pulmonary flow, a drop in the SATs would be a significant finding that duct is closing. So our team need to know that what we're looking for is the saturations, and not bother these babies all night with unnecessary kind of gases and femorals if they're not required. But it's important that if it is a baby who, for example, a coarct or something like that, that we need to be doing gases and femorals, that we know that we're doing that. Also, for example, some babies, so for us, with our PPHM babies, a widening pre and post ductal SATs is a concern. But for some babies, for cardiac lesions, we want a bit of a difference, because that shows the duct is still open and patent, and that closing is a worry. So it's important that our team know what to look for as a sign of deterioration, and our ongoing management for that baby. Some babies require very specific management. So for hyperplastic left heart, it's really important to monitor both the pulmonary and the systemic circulation, and there's lots of things that we need to specifically look for in these babies and how we manage them. And it's important that the team, again, know exactly what we're looking for and what to do with these babies. And from a neonatal perspective, all babies get what's called a NIPE, which is a newborn infant physical examination, and that should be done in the first 72 hours. It's really important that we get that done as soon as possible, because that prompts us not only to look for other conditions that might be related to the heart condition, so looking at the palate, checking for any clefts, looking for any other associated features that we would see more commonly in babies potentially that have a heart condition, but also before the baby gets whisked away to theatre or to the cardiology ward, we want to make sure we've done all of the normal things that we do for any baby, whether they have heart conditions or not. So that is the end of the presentation.